Yeah, everyone. Hi, everyone. My name is Addie. I am the REACH program assistant here with Association of Immunization Managers, or AIM. I will give everyone about 1 more minute to get everyone into the meeting, and we'll get started. All right, it looks like we have a good group here, so I'll go ahead and get started. Like I said earlier, my name is Addie Voz. I am the REACH program assistant here with AIM. Welcome to our Back to Basics COVID-19 webinar hosted by our subject matter experts. And to give a quick introduction, we have Dr. Yabo, Lisa Jack Carroll, and Dr. Fiskus here with us today to give us all the basics on COVID 101. And starting off with Dr. Yabo, she is a pediatrician with over 20 years of experience in private practice in urgent care. As a public health professional, she worked at the CDC in the Immunization Service Division for several years, training healthcare providers across the country on vaccine recommendations, and also led the ACIP work group on the childhood immunization schedule during that time. She currently serves as a public health consultant and subject matter expert to AIM and other national organizations. And then we have Ms. Jack Carroll, who is an independent consultant with over 20 years of immunization experience working at the state, national, and international level. She began her career in Michigan's immunization program and later spent 10 years at the CDC working on domestic and global immunization projects. She currently consults for AIM, as well as other national organizations and the World Health Organization Regional Office for Europe. And then we have, last but not least, Dr. Fiskus, who is a board-certified pediatrician with nearly 30 years of experience in pediatrics and public health. Most recently, Dr. Fiskus served as the medical director of the Tennessee Department of Health's Vaccines, Preventable Diseases and Immunization Program, and led the state's COVID-19 vaccination efforts until July 2021. When she and her family relocated to Virginia, until July 2021, and when she and her family relocated to Virginia. She now advises national organizations such as AIM on public health policy and strategies. Dr. Fiskus is the past president of the Tennessee chapter of the American Academy of Pediatrics and now serves as a board of directors of the American Academy of Pediatrics. So I will go ahead and give the reins over to Dr. Fiskus and our subject matter experts for the rest of this webinar. So I'll stop sharing my screen so Dr. Fiskus, you can take control.
All right, thanks, Addie. Give me just a second here to get our presentation up. And we'll get started off with Dr. Yabo.
Awesome, thank you. Thank you so much, Addie, for such a warm welcome. And welcome to all of you. Some familiar names and faces from the iReach program. Shout out to iReach, and also from PAVE and our fellow colleagues at AIM. So thank you all for joining us. This may be a refresher for many of you. However, we realize that you may have new staff on board. You may have people who are new to the immunization world, and just really just wanted to get an update of what is now being set as far as guidelines regarding COVID-19 disease and the vaccine. So we wanted to just give you a snapshot today. As we know, this pandemic is ongoing. We're seeing cases around the world. Unfortunately, here in the US, we're still seeing nearly 400 deaths per day. So this disease is not over. It's still here, unfortunately, with us. The symptoms, you're probably familiar with it, either if you or a family member have had COVID yourself or know of others. We continue to show fever, chills, sore throat, things that can also look like the flu or maybe even strep throat. So it's so important to get tested. We're seeing less symptoms of loss of taste or smell with this new variant that we'll talk about, the BA.5 variant. We saw that symptom earlier on in the pandemic, but not so much so right now. So with that being said, there have been several strains that have been identified over time, with the BA.5 being the most common one right now in the US. So as you can see here, this is a table that's put out by the CDC every week. And it shows that the most common variant that we're seeing now, variant of concern, is the BA.5. But we're also starting to see another one called BA.4.6, which is rearing its ugly head. Is about 6% of cases now and is being seen globally as well. And we're keeping a close eye on that as well, because it's a subvariant. So what are variants? So let's watch this 1.5-minute video for a minute. Awesome. And we'll include the links to all of these in the chat by the end of this session. So you'll have access to this. We thought it was a good 1.5-minute video that you could share in your communities or on your social media pages, describing what variants are and how they occur. So when we talk about cases now and case trends in the US, we are still seeing cases per week or daily trends that show the number of COVID-19 cases in the US, still around the 100,000 per day as far as the number of cases around the US. The prior peaks or heights there that you see on the curve are when we had the Omicron variant circulating earlier this year, but unfortunately, we're still continuing to see that level, steady level of cases starting to slow down a little, but we really can't be sure. We'll have to look at it a month from now and see if there truly was a slowdown or not. We also have the opportunity to look back since March of 2020 and see who's been affected the most in terms of age group from COVID-19 disease. And on a weekly level, unfortunately, we're still seeing our older adults being the most affected. 75 years and older being the most affected as far as the number of deaths from COVID-19 of all age groups. So something that's so important, and as you'll hear from Dr. Shelley later when she talks about the importance of vaccination and booster doses, particularly in older adults, to make sure our older population are protected. And what about our children? We know that children do get seriously ill from COVID-19 disease as well, despite what we may hear. We know that during the peak of the Omicron variant, which was probably earlier this year, January through March or so, that children were 14 and a half times more likely to be hospitalized. And that's children younger than the age of 5 who have not had a chance at that time to be vaccinated, more likely to be hospitalized during the peak of that Omicron variant. And then there's also something called MIS-C, which is inflammation of the organs that can occur in children after having had COVID-19 disease. It can affect their hearts and lungs and their kidneys, etc., and can make kids very sick. And we've seen over 8,000 of these cases since the beginning of the pandemic and over 70 deaths as a result of this MIS-C. So it's not just benign, it's not just a common cold or the flu when our kids get COVID-19. We also have included here some links to some great resources from the American Academy of Pediatrics on the healthychildren.org website, available in both English and Spanish, that share some more information about kids and COVID-19. Also, we can look at our race and ethnicity data and see that since March of 2020, as far as hospitalization rates, not just who got COVID, but who got COVID to the point that they got very sick and needed to be hospitalized. We still continue to see disparities through June of this year with our indigenous populations, American Indian, Alaskan Native, followed by Blacks, and then followed by Hispanic populations bearing the brunt of hospitalizations from COVID-19. And as we know, there's so many social determinants of health, there's so many reasons, including structural racism, that leads to these disparities that continue today. And that's the work that we do to make sure that we protect the communities that we serve by encouraging vaccination to ensure that these hospitalizations don't occur. One of the things, this table has been available on the CDC website since the onset of the pandemic, and we're still seeing, again, this disparity in terms of hospitalization and deaths, highest in the American Indian, Alaskan Native populations, followed by the African American and Hispanic populations compared to their white counterparts. So again, information to share with you. So with that, I will move over to Dr. Shelley. Thank you.
All right, thanks, Dr. Yabo. So, you know, we've talked about this for a long time now, but just to review the ways that we prevent getting COVID-19 is to prevent getting infected with the virus to begin with, and that's by staying up to date on our vaccines, including getting the recommended boosters, getting tested when we have symptoms, and staying home. Even if we don't have a positive test, but we suspect that we may have COVID-19, we need to stay home and away from other people who could get seriously ill. Seeking treatment is really important and really something that I think is still very much minimized. I hear a lot from people who have tested positive and they say, well, I'm not that sick, so I'm not going to go get treated. When really, you know, what we're trying to do is prevent people from getting really sick. And so getting treatment is important. And then wearing a mask if you are in a home with someone who is at high risk, or, you know, certainly out in your community if you're in a place where you're going to be gathering, especially if there's high transmission rates in that community. So this is a great, simple little graphic from CDC to just remind everyone to get those simple measures in place to make sure that we're protecting each other. Let's talk a little bit about the vaccines in particular. And, you know, this is something that is it's just not easy to understand about the different types of vaccines. And so we're going to try to walk through some simple graphics to help kind of plant a process in place and make it easier for you to distinguish between them. So first, just as a, let me go back. First, just as a reminder, we have 3 different types of vaccines that are available. The mRNA vaccines, which are the Pfizer and Moderna vaccines, the viral vector vaccines, which are the Johnson & Johnson vaccine, and then the protein subunit vaccines, which is the newly authorized Novavax vaccine. it is really complicated to go through how you dose these according to ages. So really what you need to do is just have the cheat sheets at your fingertips. This is the pediatric one. It's obviously very complicated. It depends on what age the child is as to how many doses they get, and how many boosters they get, and if they're immune compromised or not immune compromised. It's very complicated. And CDC hasn't even yet updated this particular chart to show that Novavax is now authorized for children 12 and up. So there are 3 vaccines that you can give children who are 12 and older. There are 2 vaccines that you can give children who are 11 down to 6 months, and that's the Moderna and Pfizer vaccines. The adult chart is equally complicated with all 3 different types of vaccines. And again, you might need 4 doses, you might need 5 doses. It depends on your age and your susceptibility to getting seriously ill with COVID-19. And then they have this bubble sheet here, which has not been updated yet on the CDC site actually this one has, to show that Novavax is available for 12 and up. So pick your poison as far as cheat sheets, whether it's a bubble sheet like this or the graph, the tables before, but have something at the ready so that you can answer questions about how many doses someone might need and what those intervals are supposed to be. So let's talk for a second about the individual vaccines, starting with the mRNA vaccines. So as I said, the mRNA vaccines are recommended for anyone 6 months and older. There are 2 doses in the primary series, but if you're a little kid, you need 3 doses of Pfizer. And if you're immunocompromised, you also need 3 doses. And then depending on your age and your health, you might need 1 booster if you're under age 50 and otherwise healthy, but you might need 2 boosters if you're over age 50 or if you're immunocompromised. So again, having those charts available to make you, have that information at hand is important. Don't just go by memory because these things change all the time. And then how do they work? So let's walk through this little cartoon. Some of you may have seen these before if you've tuned into our hot topic sessions, but I think the more times we see it, the more times it starts to make sense. So with mRNA vaccines, we start with a message. So just think about this as a little message, a little recipe that is made in a lab. That is the recipe for how to make the spike protein that sits on the outside of the SARS-CoV-2 virus that causes COVID-19. And they take that message and they put it into vaccine vials, and that is what is given to us in a shot. So we get this message in the shot, and it goes and it gets taken up by some of the cells in our arm. So that's what those green kind of blobs are representing some of the cells in our deltoid muscle in our arm. And so those cells see that message, and that message tells them that they need to make the spike protein. So the cells say, okay, I'll make spike protein. So that's what these purple things are. This is the spike protein that's on the cover of the COVID, the virus that causes COVID-19. Well, after just a little bit, the message just disintegrates. So think about Mission Impossible. You've got 5 seconds and this message is going to spontaneously destruct. That's what happens. The message goes away. It's very unstable, which is why we have to store these vaccines under such strange conditions like ultra cold freezers. It's to keep that message stable. This is a very, very fragile little message, and it just doesn't stick around for very long. So the cells stop making the spike protein after a very short period of time. But they've made enough of it for some of our immune cells, that's what these little pink ones are, to take notice of that protein and say, wait a second, this protein does not belong in this body. And I'm going to create some antibodies, which are these little Ys that are here, to go and attack this protein and attach to it to signal to our immune system that this stuff doesn't belong here and we need to get rid of it. So those little antibodies go over and attach to those proteins, the spike protein. And then some of our immune cells, our soldiers, come in and they're trained to look for that antibody that's attached to something and get rid of it and destroy it. So the spike protein goes away. Now what's left are these antibodies and these soldiers. And they're sitting around kind of surveying the area, looking for more of those little spike proteins. So when the virus comes in and that little spike protein is on the cover of the virus, that immune system is already revved up to identify that. They've got the wanted poster already for the spike protein. It doesn't matter that it's attached to a virus. They just see that spike protein and know to get rid of it. So those antibodies go over and they attach to that spike protein. And then it tells those soldiers, hey, this is something to get rid of. And the soldiers go over and they decide that they're going to eliminate the spike protein. And when they do that, the virus goes with it. And so now they're still around waiting for maybe another time when those spike proteins might show up, whether it's in another shot and it reminds it, oh, okay, we're still looking for this. Here's my spike proteins again. We need to make more antibodies and get rid of it. Or it's on the cover of a virus because you've gotten infected maybe another time. So hopefully that helps it. Now, it helps you kind of think about this process. Now we're going to go through this same cartoon with the other two types of vaccines so you can see exactly how they differ from this one. And it's really just a step or two that's different between these three vaccines. One of, I think, just the best videos, and if you've tuned into Hot Topics before, we played this back in July, but I think this is the best YouTube video to describe exactly what I just showed you in that cartoon. So I'm going to play this 1 minute little snippet for you on FORCANs and how mRNA vaccines work.
You need to make this. What is it? It's a part of a virus. Just a part of it, not the actual virus. They're called COVID-19. They have FORCANs and they're coming. FORCANs? Please. Ah! What is this? This messenger told me to make them. I've never seen these before. I'll make some new antibodies to get rid of them. Seize the forks. Nice body. Going to make this place my new home. FORCANs. Seize them. Ah! Ah!
So simple 1 minute video that that helps to drive that whole process home. So let's look now at the viral vector vaccine. So again, this is your Johnson & Johnson vaccine. It's the one that came out about a year ago now. Started out as 1 dose, and then they figured out pretty quickly that we need 2 doses to keep that lasting immunity. It is only for 18 and up. And then if an individual is over the age of 50, they need to get 3 doses with a booster being one of the mRNA vaccines. If you're under 50, that second dose can either be a second Johnson & Johnson vaccine or it can be an mRNA vaccine, either way. But because there is a rare incidence of some blood clots in a very small number of people, and there are safer options available that do not cause that problem, it is recommended that people only get the J&J vaccine if they can't get one of the other vaccines, the mRNA vaccines or the Novavax, or if they just don't want to get one of the other vaccines. And this is the only way that they're going to get vaccinated, then the risk of getting this vaccine is lower than getting than the risk of getting COVID-19 from getting an infection. So how do these work compared to the mRNA vaccine that we just looked at? So we start out in this case with the message again, just like before, but this time, instead of putting the message directly into the shot, we're going to put the message into a virus, a different virus. It's not the one that causes COVID, but it's a virus that has been weakened so that it really can't do much. It can't make copies of itself. It can't infect people, but it serves as sort of a Trojan horse. When we give it to the body, it can then take the message in. So they combine the message with this virus in the lab. They put that virus that now has the message in it into the shot. And that's what's given. And again, it's taken up by the cells in our arms. So this time, those little viruses that are really weak and don't really do much, they get into the cells and they give the message to the cells. And then the same process happens that happened in the mRNA vaccine. The cells are told by the message to make the protein. The body sees the protein, knows that it doesn't belong there, makes antibodies to the protein. The antibodies go and latch onto the protein. Oh, and the message went away. So we're no longer making these proteins. The antibodies latch onto the proteins and tell the immune system that this is something that doesn't belong here, and the immune system destroys the proteins. But again, now the body is primed and it's watching for those proteins to come up again. So now when the virus hits us, those antibodies go and attach to the protein on the cover of the virus, and they signal the immune system to go and get rid of the virus. And then everything sticks around and waits to see if they see the virus again. So very same process as the mRNA vaccine, except instead of the message being in mRNA and given directly to our cells, this time the message is incorporated into a weak virus that brings the message to our cells instead. So not a lot of difference between these two vaccines. So let's talk now about the third type of vaccine, which is the protein subunit vaccine. And so this is a vaccine this is the Novavax vaccine. It's recommended for 12 and up now under emergency use authorization. And it just got extended to 12 and up just a few days ago, last week. So it came out for 18 and over, quickly went to 12 and up. It is 2 doses between 3 and 8 weeks apart. And again, it's a shot given in the muscle. As of right now, it is not authorized to give as an additional dose for people who are immune compromised, and it is not authorized to use as a booster, but they have asked FDA for authorization to use it as a booster, and we may see that come out pretty quickly. So expect that this guidance is probably going to change. So how do protein subunit vaccines work? Well, it's kind of the same song and dance again, except this one is a little simpler. So this time, oh no, okay. So I didn't have my little proteins in there, but pretend that those little purple proteins are what is in the little vial and then put into the vaccine vial. So here we're getting a shot of the actual proteins. So instead of the body cells having to make the protein, we're just going to give the proteins and cut out the middleman. So those proteins go into our arm, and the body, just like before, sees these proteins, says this doesn't belong here, makes antibodies attached to the proteins. Cells come in and say, we got to get rid of this, get rid of the proteins, stick around, see the virus come in, see the proteins, antibodies go to the proteins, cells come in to destroy the proteins, and as a result, they get rid of the virus. So it's the same concept, except now instead of the message, we actually just get the protein instead. So it's a little easier. These are the types of vaccines that we have had for lots of things like flu and other viruses, pneumococcus, lots of other things. So this is a fairly easy technology that's used, and something that some people might be more comfortable with if they get kind of itchy and scratchy about the whole mRNA thing. Then this is akin to the other vaccines that they got when they were kids, and maybe that can give some reassurance to them. This vaccine is a little bit different in that it is called adjuvanted. And what an adjuvant is something that they put into the vaccine just to make the body take notice of those proteins a little bit more. So it causes the body to kind of, instead of saying, oh, look, proteins, it says, oh, look, proteins. So I'm going to show this quick little video. Now, this little video does not have any audio to it. So don't worry, your speakers are working just fine. It just doesn't have audio. So hang on and watch this one for about a minute. And just by way of full disclosure, GSK does make vaccines, and they were the manufacturer of the Novavax vaccine. Okay. So what to expect after vaccination? So hopefully you've all been vaccinated and you kind of know what this looks like, but just in case, or in case maybe you didn't have any kind of reaction after your vaccine, it is not unusual to feel a little bit yucky for a couple of days. There might be some low-grade fever, there might be some body aches. They usually just last a day or two and then they go away. You can treat them with ibuprofen or acetaminophen, which is Tylenol. It is a little less common to have higher fevers or really feel terrible, like in the bed terrible, but that can sometimes happen, and it might be a little more likely to happen after the second dose. There have been reports of severe allergic reactions like anaphylaxis, like people might get if they're allergic to peanuts or bee stings. It is very rare for that to happen, but it can happen, and if it does, then they should not get another dose of that kind of vaccine. And then there are rare cases of myocarditis and pericarditis, which is swelling and inflammation of the heart muscle or of the sac that is around the heart muscle that can cause chest pain, and sometimes end up putting someone in the hospital or needing to seek medical assistance. This usually happens in younger people, usually in younger males, and is a little more common to see that after the second dose as well. It is still very rare, and the actual infection from the SARS-CoV-2 virus can also cause myocarditis and pericarditis, and does so more commonly than if you were to get the vaccine and get myocarditis or pericarditis. So we don't want to discount this, but it is unusual, and people are still at greater risk of those conditions from getting sick than they are from getting the vaccine. As we discussed, there are rare cases of blood clots, something called thrombosis with thrombocytopenia, that have happened with the Johnson & Johnson vaccine. And because of those rare cases is why that vaccine is not recommended unless someone cannot get one of the other vaccines or just will not get one of the other vaccines. And then it is safer for them to get vaccinated with J&J than it is to go unvaccinated. And so far, reactions after booster shots are pretty similar to the reactions that people get with their first or second shot. I know for me, I've had both Pfizer and Moderna vaccines. I got really bad body aches with the Moderna vaccine, and just felt kind of tired after the Pfizer vaccine for a day or two, but nothing serious. So let's talk a little bit about treatment. And this is something that I really want you to think about, because this, as I said earlier, is where folks just aren't seeking treatment, and treatment is readily available now. And there's really no reason to take your chances if you get COVID. Take your chances on getting sick enough to end up being hospitalized or have long-term consequences from that. So if you're more likely to get sick, especially if you're age 50 or older, or you're someone who's not vaccinated, or if you have certain medical conditions, which many of us have this list of medical conditions, then you really should seek treatment right away. Don't wait and see to see how sick you're going to get. Just go ahead and get treated. This list is pretty huge. When you look at obesity with a BMI over 30, that's about a third of us in this country. People who are smokers, current or former smokers, people who are pregnant, people who have cancer, heart disease, kidney disease. If you have any kind of neurological conditions, if you have a mood disorder, this is, most of us have something that's on this list. So unless you are under the age of 50 and just absolutely in pristine health, you really should contact your healthcare provider or go to a test and treat site to get treated for COVID, hopefully within the first 48 hours of you realizing that you have COVID. There are several different treatment types. for people who are not in the hospital. And FDA has authorized several of those. Paxlovid is the one that's been around the longest, and that can be used in adults and in kids. Remdesivir is the one that's been around the longest, and it can be used from babies, from newborns, all the way up. And then molnupiravir, terrible with these names, is just for adults. And then we did have more monoclonal antibodies. So these are antibodies that are collected from people who have been infected with COVID, and then they're put through a purification process and then given to people who need a little extra help fighting it. So instead of having to make your own antibodies, they actually give you antibodies to COVID, or to the virus that causes COVID. We used to have several of these. Now there's only one that's really effective with Omicron and BA4 and 5, and that's bebtelovimab. Oh my gosh. So anything that ends in MAB is a monoclonal antibody. And I want my next career to be naming drugs, because people just throw consonants together. Anyway, I digress. You can get an infusion of this if you qualify and if you're 18 years or older. There are lots of treatments that are given in the hospital. Some of them include these treatments. So if you were to be hospitalized, you're probably going to end up with an antiviral and an MAB and probably steroids and maybe some other things. But that's going to be within the realm of the doctors that are treating you, and hopefully you're going to get vaccinated and boosted, and you're never going to end up in the hospital to begin with. So I'm not going to talk about those. So that's it for me. I'm going to hand this over to Lisa, who's going to take us through a refresher on long COVID and some FAQs.
Thanks, Dr. Shelley. So I'm sure you've all heard of long COVID or post-COVID. Some people who get infected with COVID can experience long-term effects from their infection. So these post-COVID conditions can include a wide range of different health problems, and can last weeks, months, or years. And it's more common in people who had severe illness, but it can actually happen in anyone who has COVID infection. And there's a new study that was just published this month in the Lancet Psychiatry. And what they looked at is the neurological and psychiatric risk after SARS-CoV-2 infection. And so this was a retrospective study. They looked at 1.4 million patients who had had COVID infection between January 2020 and April 2022. And they matched them with other patients that had had a non-COVID respiratory condition. And what they found was that the people who had had COVID, that their mood disorders like anxiety and depression largely decreased within 1 to 2 months after infection. But things like brain fog, dementia, psychotic disorders, and seizures were still increased in the adults who had had COVID infection after 2 years. They found that children were not at an increased risk for mood disorders, but that they did have an increased risk of the same of brain fog, insomnia, brain hemorrhage, stroke, psychotic disorders, and seizures 6 months after their infection. And the outcomes were similar whether people were infected with Alpha, Delta, or Omicron variants. So just an important reminder of, reasons to try to not get COVID infection. And then we have some COVID myths and FAQs that we wanted to go through with you all. So, and the first one is, this is something that you might hear, a good vaccine shouldn't need a booster dose. And so the response that we have to that is that we do know that the COVID vaccines are working well to prevent severe illness, hospitalization, and death in the individuals who've been vaccinated, especially those who've gotten or up to date on boosters. But we do know that protection decreases over time. And that's why the boost is needed to prolong that protection. And also because, we saw with those variant slides that Dr. Galbo showed that this Omicron is constantly changing. And so that's why this fall we will have updated boosters that will include more variants so that we can be protected better. Another one that's a myth that you might hear is that you can get COVID-19 disease from the vaccine. And here's a response that you can use. So the COVID vaccine cannot make you sick with COVID disease. And none of the authorized vaccines in the US contain the live virus that causes COVID-19. And then the next one that you might hear is COVID-19 disease is not serious in kids. And we know that it can make children and teens very sick and sometimes need hospitalization. And children have died from COVID-19 disease. And healthy children, as well as kids with underlying disease, can have severe illness from COVID. We know that children and teens can develop MIS-C, and the MIS-C is found at higher rates among Hispanic and Black children. And then we saw from that other study that children and teens can also experience long COVID, and they can be physical or mental conditions and can last for weeks or months and can affect their quality of life. And then you might hear people say, I'd rather just get infected with COVID. It's going to give me better protection than the vaccine. And as a response to that, you can try to remind them that COVID-19 vaccination is safer and a more dependable way to build immunity than getting sick with COVID-19 disease. And then some people feel COVID-19 vaccine isn't worth it, that you might still get sick even if you are vaccinated. And as a response to that, we know that some people will get breakthrough infections after vaccination, but again, you're less likely to be hospitalized or die from COVID-19 if you are vaccinated. And then we have some data to share. This comes from the CDC website, and it shows the rates of COVID deaths by vaccination status in people 5 and older. And the black line on the top shows the death rates among those who were not vaccinated. And then the blue line shows the death rates among those who were vaccinated with at least a primary series. And we also see in the little boxes at the bottom that unvaccinated people that were 5 and older had 2.1 times the risk of testing positive and 5 times the risk of dying from COVID-19 as of June 2022, and also 2.4 times the risk of testing positive in July compared to people who are vaccinated with at least a primary series. So big impacts there. And then this graph is a little bit different. It shows the rate of COVID deaths by vaccination status for those 50 and older who had 2 booster doses. So again, the black line are the deaths among the unvaccinated. And then the dotted blue is people who had just the primary series. The solid blue is those who had primary and 1 booster dose. And then purple is those who had primary series and 2 booster doses. So you can see that the greatest protection against death is for those who were fully vaccinated and had both of their booster doses. And then as of June 22, of those 50 and older, unvaccinated people had 14 times the risk of dying from COVID compared to people vaccinated with the primary series and 2 booster doses. And then for that same population, they had 3 times the risk of dying from COVID compared to people who were vaccinated with the primary series. Oh, sorry, for that next category, among people 50 and older, vaccinated people with the primary series and 1 booster dose were at 3 times the risk of dying compared to people vaccinated with a primary series and 2 booster doses. So that extra booster dose does make a difference. You might get asked, can we mix and match COVID-19 vaccines? So the current recommendation is that it's preferred that you use the same vaccine for the doses in the primary series. But for booster doses, mRNA vaccines, which are the Moderna or Pfizer, are recommended. And it can either be the same vaccine that you had for your primary series or a different vaccine. And then I think this is the last one. It's saying there's the myth that COVID-19 vaccine can change your DNA. But we know that COVID-19 vaccines don't change or interact with your DNA in any way. And I think that is all of our myths and questions. So now we're ready to take questions from the audience. So please put your questions in the chat box.
So I did see one question that came up in the chat, and that was how long a 2-year-old should wait from having COVID-19 until they get vaccinated. So the answer, according to CDC, is that they can wait for up to 90 days if they wanted to, if the parent wanted to, but there's really not a reason to wait. And especially with the development of new variants, they may not want to wait. So as soon as they're better from their infection and symptom free, in that they're not having fever or, in bed, they might still have a little cough or something, and that's okay. But as long as they're over their acute infection, they can go and get their next dose of vaccine.
Great, and I saw I put in some answers. Hopefully that will help for Sarah. She'd ask about the vaccine schedules in Spanish. They're not directly translated into Spanish at this time, but I did include a couple of web pages that will answer questions on how to stay up to date on your COVID-19 vaccine schedule. Hopefully that will help.
And there's one from Melissa. Does the body have long-term memory to fight COVID-19 after the antibodies begin to fade away? And it does. So we have those cells that are also there. So there's kind of two parts to the immune system. One is the antibodies and one is the cells. And so even if we couldn't detect antibodies, there may still be some memory there from the other part of your immune system that could provide some protection. So this is why antibody tests are not a great thing to do, because you might be protected against the virus and not have good antibody levels, or you may have really high antibody levels, but those antibodies might not be effective for you. So we and CDC has always discouraged getting antibody levels as a way of trying to determine if you have protection against COVID. It's better to just go ahead and get the vaccines as they've been recommended. But it is possible that over time you may still have some protection and may not get as sick as you would have been if you didn't ever get vaccinated or if you were never infected. Problem is, we just don't know how protective any of that is, and we don't have good testing to figure it out. What other questions do you have? You can either type them in the chat, or if you want to unmute and just ask them, you can do that too. So Alondra is asking, is there updated information on long-term effects on pregnant women who are unvaccinated but had COVID long-term? So we know that having COVID when you're pregnant increases your risks of having a poor outcome, of dying, of having a premature infant. I have not seen specific studies on long-term COVID or long COVID. Lisa or Dr. Yabo, have you seen anything?
Not long-term, just during the pregnancy and immediately after birth. Mm-hmm. But definitely the early studies that came out, just to add on to that, were very convincing in terms of making sure that pregnant people get vaccinated, because the rates of ICU admission, people having to be on the ventilator who are pregnant and caught COVID, very high, especially in African-American and Hispanic women in particular. So important to get the message out. And we encourage you to save the chat box. And I think Lisa can explain it better how to do that. You shared that on Hot Topics, how to do that. Yeah.
Yeah, if you open up the chat and then in the lower right corner, there you'll see 3 little dots. And if you click on that and then say save chat, it should download a copy of it to your computer. And then you'll have all of the URLs that we shared.
And as we always say, no question is a silly question. If you're thinking about it, somebody else may have it. So if there's something that's burning in your community that you're hearing that you want to ask about, go ahead. We've heard quite a bit, so we'll be happy to help answer that.
All right, so we were actually going to cover COVID and flu during this event today and realized that there was so much information that it was going to take us forever to cover it all. So stay tuned for part 2 of this webinar, which will be on flu. And we plan to do that in mid to late September. Hopefully CDC will have their guidance and their MMWR out by then, so we can use that information. And Anna's asking to repeat how we download the chat. So Anna, in the chat, you should see 3 little dots next to the smiley face where you would be typing your message. And if you click on those 3 little dots, then you should see an option to download the chat. Oh, you don't have that option. Okay. So we can, okay. So maybe it's only with the presenters. We can download the chat and we can send it out to you.
I can also, if there's any resources that you all missed or I missed in particular, you can always email iReach and I could always send you a copy of the link to the resource as well.
Thanks, Addie.
Thanks.
Yeah, there was a question that just came up about the new boosters. The ACIP now has a meeting calendared for September 1st and 2nd, where we assume they will be discussing the new bivalent booster and voting on that. Haven't seen the agenda for that meeting yet, but I assume that's what's going to happen at that meeting because it is newly calendared. They weren't supposed to be meeting until October. So if that happens, and so what will usually happen with those meetings is September 1st, they'll get all the data and the information about the boosters. They might cover some other business. And then typically that afternoon or the afternoon of the next day of the meeting, which will be September 2nd, they will have a vote to recommend or not recommend the authorization and use of the bivalent booster. So February, September the 2nd is Friday. And if they do as they typically do, that means that that's the Friday before a 3-day weekend. They don't ship vaccines on Fridays. And then Monday is a holiday, so they would ship on Tuesday, which means bivalent vaccines could potentially be available as early as Wednesday of next week, the week after next, if that happens, the Wednesday after Labor Day, if things follow the path that they've been taking with all of the other vaccines. So as far as talking points, then this is a vaccine that is specifically tailored to add protection against the new Omicron variants like BA.5 and BA.4 that will be added to the original Pfizer and Moderna vaccines. So they would get the same original Pfizer and Moderna vaccine plus this new addition to it to help cover the Omicron variants. So there is one vaccine made by Pfizer and one vaccine made by Moderna. So we're not throwing a new manufacturer in the mix here. There's not a lot to approving these vaccines except to show that they work. Because it's the same exact technology, it's mRNA technology, none of that is changing. They're just putting in a message that is just a little bit different to tell the body to make a protein that looks just a little bit different to the original one. So our bodies would make the original protein, and then it would make this new variation of a protein, which might look more like a spork than a fork. And then our bodies would create antibodies to both of those things that look a little bit different from each other and be prepared to fight those Omicron variants too. So look for that potentially 2 weeks from today, or maybe a few days after that, as long as everything goes well with ACIP September 1st and 2nd.
Awesome, awesome. There was a question we wanted to address with flu season coming up. How would you address the similarities with COVID-19 to community members? Great question. We do have a slide that really compares and contrasts the two, but both of the diseases are very similar, right? You can have fever, chills, some of the same symptoms. They both affect the lungs and can cause coughing and wheezing. They can both lead to hospitalizations and deaths. That's how they're similar. Because of masking and other methods we've had in the last 2 years, we have not seen a lot of flu, but we're starting to see that in other areas that are seeing flu now, like in the Southern Hemisphere, Australia, South Africa, they're starting to see flu cases that are at the same level as pre-pandemic levels. So it is kind of scary, especially for people who have underlying medical conditions, someone who has asthma, chronic lung, heart disease. If they got both flu and COVID at the same time, could be pretty devastating. So the message is really get vaccinated against both flu and COVID-19. You can get both your flu vaccine and your COVID-19 vaccine booster if you're due for that at the same visit. Is okay to do that. So we really want to encourage vaccinating for both, and we'll definitely have more information on our next webinar as well to share about the flu. So thanks for that question.
And then there's a question about how common are breakthrough infections after vaccination. So Lisa showed that one slide that showed the risk of death if you have been vaccinated, even with the primary series and one booster, compared to people who've had the primary series and 2 boosters. I don't have specific stats on how common it is. I would say common. But remember that getting vaccinated and being fully vaccinated, including boosters, is the thing that helps to keep you out of the hospital and out of the morgue too. So if we didn't have that benefit, it may not be worth getting vaccinated, but we do, and that's incredibly important. So Lisa or Dr. Yabo, have you seen specific stats on breakthrough infections? They're really hard to track.
I was gonna say, since there's so many people doing so much self-testing, I think that makes it almost impossible to know because we don't have good testing data, right?
Yeah, it was much easier to track this early in the pandemic when all of the testing was sort of controlled and everybody was getting PCR tests, and then they could link to the labs and see if someone had been vaccinated or not. But with as many home tests as there are now, it is unusual to end up hospitalized or dead because you were if you were fully vaccinated and boosted from this. Yes, the UK is using the Moderna bivalent booster now. Thanks, Dr. Yabo. Yeah, they started using theirs, I think, last week or the week before. Everything runs together in COVID time. But yeah, they're going to have probably a few 100,000 or even maybe a couple million people ahead of us by the time we get our boosters out.
Sorry, that's just response to Jennifer. She had asked what manufacturer is developing the bivalent. That was a feedback, so let's lock that in there.
All right, well, we are at time. So thanks as always for joining. And yes, you will get notification of the flu webinar. So watch your iReach materials. Plus we'll send out blasts to our partners to make sure that they're aware of that. But look for it probably around the week of September 19th, somewhere in there.
Thank you, everyone.
Thank you all.
Thank you.
Great rest of your week.
Thank you.
Great job. Thank you.
Thank you.
Thanks.
I agree.
Thanks, Hannah.
Thank you so much.